Good afternoon, everyone, and welcome to the Beta Thalassemia webinar series. And today we have organized this session. I would like to particularly thank Dr. J.S. Arora for organizing this webinar session. And for today, moderator will be Dr. J.S. Arora, who is a General Secretary at National Thalassemia Welfare Society. So, welcome, sir, and thank you so much for organizing this session. And over to you, sir, for the welcome remarks. Thank you.
Okay, thank you, Manisha. Good afternoon, everybody. First of all, I'd like to thank ECO Team India to giving us opportunity to hold this an important webinar. And I welcome Dr. Sunita Sharma, who is Director General of Health Services. She'll be joining us at around 3 o'clock because she's busy with another meeting. And she has been very sporting even when she was at Lady Harding Medical College. And now I'd like to welcome Madam Vanita Shrivastava. I think she doesn't require any introduction. Anyone in India who is in the care, cure, or control of thalassemia, he or she knows Dr. Mrs. Vanita Shrivastava. She has done a lot of work during last decade or so that there is quite change in the perspective of thinking of thalassemia. And she has made it as a topic of discussion at the Ministry of Health and Family Welfare. That is the most important thing which we have been stressing for so many years. I'd like to welcome Dr. Jagdish Chandra, who is a professor professor of pediatric at ESI Hospital, Faridabad. Earlier, he was the director of Lady Harding Medical College and director of Kalavati Saran Children's Hospital. He is a pioneer of starting transition of thalassemia care in India, and he has made transition of care a movement in India, I must say, and he has been instrumental in bringing out a policy on transition of care as well, not only on thalassemia but all other diseases. So I think we should now start saying Dr. Jagdish as father of transition of care in India. That will be much better. I think nobody has done so
Not
much,
really. It is the need of the hour.
but whatever he has done, nobody else has even thought of. I must say, doing is still greater, not thought of itself. And I'd like to welcome Dr. Neeta Radhakrishnan, who is the professor of pediatric hemato-oncology and at PGI PGICH Noida. And she's doing a lot of work on especially thalassemia, I think, because no other blood disorders as well, but I know about thalassemia. Dr. Sandeep Bhalla, who is the vice president of ECO India, he will not be able to join because of some family issues at her place. I'd like to invite now Dr. Neeta. Before inviting, I'll say that this is really, as Sir said, this is a need of hour because now our thalassemics are not. I know when we started 1991, the average age was around 12 year, 13 year, 14 year. Hardly we can see any adult thalassemic. At that time, I had seen only one thalassemic adult that was 21 year and thalassemia intermedia and very bad shape. And most of them used to die around 12, 13 years or so. So now we have many adult thalassemics and they also need special care. And it is that their challenges are different. Their problems are different. Medical conditions are different. So they need adult physician to care for them. So today's topic is regarding that only. So I invite Dr. Neeta to the context of setting of context.
Thank you very much, sir. Good afternoon to all, and thank you, ECO India and National Thalassemia Welfare Society for taking up this initiative for this webinar. So as J. Arora sir just mentioned, that gone are the days when thalassemia used to be only a condition which was pertaining to children. Now with better treatment, I agree that there are a lot of gaps in care even now, but the condition has drastically improved in the last 15 to 20 years with the efforts of the Government of India, Ministry of Health and Family Welfare, National Health Mission, and all the patient advocates like Dr. Jayasar Arora himself, who's been working tirelessly for the cause of children with thalassemia. So because of this, there are now children who are surviving into adulthood and who are doing really well. So now we see people who are entering into jobs, who have their own families, and that's very fulfilling to see that. So in this context, we need a formal transition process, a coordinated transition program that ensures continuity, gives the patients that feeling that they'll be taken care of the same way that they were being taken care of till 18 years of age. So that is important, so that all the complications, so most of the complications pertaining to iron overload start setting in after 10 years of age, and then that keeps on increasing, and the need for comprehensive care just keeps increasing as the age increases. So for in that setting, we need a structured program of transition and guidelines to help us support this, so that all centers, all medical colleges with medicine Department of Medicine units have an area for thalassemia patients, or at least the thalassemia center where the patient has been treated should have both pediatric and adult physicians, so that those who have crossed 18 years can be taken care of by the adult physicians. And not just a physician, but we need coordinated care from cardiologists, hepatologists, we need even dental surgery, dentists involved, we need psychologists on board, so that all that can be career counselors. So a lot of support is needed to get this transition smoothly and to continue care into their complete adulthood, so that they can live fulfilling lives. And so in this setting, I would like to congratulate National Thalassemia Welfare Society for taking this initiative, especially under the guidance of Professor Jagdish Chandra sir, who has been the champion for this cause. And under his guidance, this document was being released by directors. There was a formal directive also to start up transitioning to adults. So because of which now we are able to show that document to empower medical colleges to, show this and start off their clinics. So that we are trying with there is a JIMS hospital, the JIMS Medical College in Noida. We are trying with that. We are trying with few medical colleges in Delhi as well. So that is the context of today's meeting. And I welcome Professor Chandra for his deliberation.
Thank you, Dr. Nita. Before inviting Madam Nita Srivastava, I'd like to welcome, I could see that Dr. Michael from Medical Advisor to Thalassemia Trust Federation, he has also joined. So I think we are proud to have you with us, and it will be, now we can call it as an international webinar by you joining with the Thalassemia Trust Federation.
Dr. Androla is also there in there.
Okay. Thank you very much. So when both of you are there, that means whole world is there. So welcome very much. So I'll request Madam Anita Srivastava to chair and introduce Dr. Jagdish as well.
You are muted, Dr. Michael.
Dr. Michael, you are muted.
Yogesh.
Thank you. Thank you so much, Dr. Arora. This has been very nice. I mean, I was just going through the topic, which is very important in current scenario. And Dr. Jagdish Chandra, we talk about, he's a pioneer in this. So we are grateful that he has given his time for such a good webinar. And transition, what Dr. Nita has said, it is very important. So while we started with this ICHS center, the idea of that we have integrated center of hemoglobinopathies and hemophilia in the district hospitals, where the patients from pediatric to the adult patients can be taken care. That was the idea which was generated in 2015-16. So when I was working in NHM that time. But now the concern is that now these patients has to be taken very proper care about when they are adulthood. And with these now while I'm working with NHA, we have 18 packages for thalassemia. That's a wonderful, which is very important, where our adult children can be taken very well care about it, be it transfusion, be it chelation, be it required dental clinics and whatever it is. So everything has been included in these 18 packages which is required for this adult patients as well as for the pediatrics. The concern is people should be aware of it. And now the time where Dr. Arora and everybody has taken up that now this is the time when we should tell our patients that these are the benefits where you can get it, and also how this has to be built. So with these words, I will not take much of your time because the time is short and we need to consider Dr. Jagdish Chandra's work, because he is going to elaborate on these things, which is very essential for all of us. And thank you, Dr. Jagdish Chandra, for giving us your time for this particular session, which is very important for current scenario. Thank you so much.
Um, Thank you, Dr. Arora, Dr. Vinita Srivastav, Dr. Nita Radhakrishnan, for organizing this webinar and the topic that I am discussing it for almost a decade now, or maybe little more than that, and not only restricting to thalassemia, though this talk is mainly on transition of care of thalassemics. So I'm really thankful to all of you for organizing this, and I see a whole lot of dignitaries here in the who are attending the webinar. So that's really encouraging to see. So I will just share my slides. Uh,
Sir, I have given you the access.
yeah,
Yes,
all
sir,
right.
you can.
So we are going to talk today on transition of care of the thalassemics because they are outgrowing the pediatric age group, and that's a happy news. And as the Dr. Neeta pointed out, that over the last 2 decades we have a sizable number. We will see those figures, correct figures, also in due course of time, and the numbers are increasing. So it's always important that we should transition them, or not only to transfer them to the physicians for the continued care. So just to begin that the thalassemia prevalence, according to even new data, the average prevalence is 3 to 4% of the carrier status, and around 10,000 to 12,000 thalassemics are born annually in our country. But today we are discussing more about the improving survival. And these are the some figures from Italy. You can see the birth cohorts, and those who were born in between 1960 to 64. You can see just about few patients were surviving. Now 1985 born, they were surviving. Nearly 60% of the patients are older than 30 years. Similar data from Hong Kong, although the numbers were small. But this data, which appeared in 2020, this shows that while 37% of the cohort which were born in 1964, around that time, they crossed over to 16 years or so, and now in 2011, nearly 90% are at 40 to 49 years, according to one publication. And we are almost reaching for the normal lifespan of these patients with thalassemia. And these figures are for transfusion dependent thalassemia, not the anti-DT. So, if we look at the Indian scenario, there is no detailed data available, and I would request that somewhere the task gets started, that what is the actual survival in, though we collated this data from 4 centers, that is DMC Ludhiana, Apollo New Delhi, UCMS New Delhi, and Jaipur Santokh Durlabji Hospital. Total over 500 cases, and of them 43% were above the age of 18 years. This is data which was compiled early in 2023. And if you look at the different age groups, so even some of 10% were between 36 to 40 years of age. And as we were discussing, many of them are well qualified. They are doing MBA, they are doing nursing, they are doing pharmacy, they are doing colleges at different MCA, BCA, etc., and they are having their own jobs. Not only they are having jobs, they are providing jobs to others by starting their own establishments. So, with this information on the increasing number of those who are crossing over from 18 years of age, the transition of care is really the need of the hours. This is not something a favor which we are doing to them. So, it necessitates a transition from pediatric care to adult care, which was unwarranted in previous generations when patients crossing over into adulthood was rarely seen. And actually, it just to affirm that as children receive optimal primary care in the in a medical practice experience in the care of children, so two adults will benefit from receiving care from physicians who are trained and experienced in adult medicine. And this is certainly more important for adolescents and youth with special healthcare needs. And that is where the term has been defined by the US Maternal and Child Health Bureau. Uh, those who have or are at increased risk for chronic physical, developmental, behavioral, or emotional condition, and who also require health and related services of a type or amount beyond that required by children generally. So, if the child is normal, doesn't have a chronic illness like thalassemia, hemophilia, or sickle cell disease, or any cancer survivor, or any other chronic disease like diabetes, etc., the requirement of those children who do not have such diseases is not much. But a child who has a special health care need because of the chronic illness, this becomes very important because they require type or amount of the related services which are beyond that is required by children generally. So the concept of transition was there in late 80s, but this definition which was given by Blum 1993 from USA, and this people have persisted. So this is almost now 3 decades, but this definition has persisted since then, and transition has been defined differently from transfer. The transition is a purposeful, planned process that addresses the medical, psychosocial, educational, and vocational needs of adolescents and young adults with chronic medical and physical conditions as they move from child centered to adult oriented healthcare systems. So it highlights transition as being a process occurring over time rather than an abrupt administrative event like now you are 18 years, you are transferred to medicine. It's not like that. So the consensus statement of Society for Adolescent Medicine stated that we should ensure that by the year 2010, this was in 2003, that by 2010 all physicians who provide primary or subspecialty care to these youth with special health care needs, they should understand the rationale for transition from child oriented to adult oriented healthcare. They have knowledge and skills to facilitate that process and know if, how, and when transfer of the care is indicated. So, what happens in for routine cases, it is automatic. The system says that you are now 18 years old, you get a OPD slip made from the medicine OPD and show there. If it is acute febrile illness or anything, and hospital administration has the cutoff for these pediatric age groups, whether it is 12 years or 18 years. Like it does vary in our country. In even in Delhi, there are not many hospitals which are providing pediatric department providing care beyond 12 years of age. So medical transition, the goal is to maximize lifelong functioning and potential through the provision of high quality, developmentally appropriate healthcare services that continue uninterrupted as the individual moves from adolescence to adulthood. And this is just to show the difference between pediatric practice and adult medical culture. The pediatrics is primarily family-centered and developmentally focused. It ignores at times the growing independence and increasing adult behavior of the child. But on the other hand, the adult medical culture is which acknowledges autonomy, reproduction, and employment issues, growth, development, and family concerns between how the physicians work and how the pediatricians work. So we discussed partly the need for transition. One is the growing number of patients with thalassemia who are now adults, and they are more likely to have comorbidities. As Dr. Neeta said, that the iron overload related morbidities, they start appearing in the second decade or later part of the second decade more often. But with increased age, it does predispose to atherosclerotic cardiovascular disease as well. We are tuned to discussing about the cardiomyopathy, which is related to cardiac cirrhosis. So they might have impaired glucose metabolism or diabetes mellitus, putting them at higher risk of cardiovascular disease, high incidence of arrhythmias. It invites concerted effort in prevention and avoiding indulgence of thalassemics in risk behavior such as smoking. So on the one hand, the patient is having thalassemia with all other comorbidities. They also are likely to have atherosclerotic cardiovascular disease, and certainly the risk behavior needs to be avoided in these patients. And the cancers, which are like hepatocellular carcinoma, lymphocytic malignancies, leukemia, etc., they are increasingly being reported in increased age group patients. Newer endocrine complications like central hypothyroidism, this is being seen in adult thalassemics. On the other hand, in regions where management facilities are improving only lately, the patients have more comorbidities. It's like the survival is improving, but the patients are still having comorbidities, and there the transition may be more challenging. So, like in Malaysia, the 45% of the patients in the adult age group, they had comorbidities with 9% having multiple comorbidities. Now, having said these things that there is importance of transition, this is really required, but then there are some perceived barriers and challenges. I have particularly written perceived word here because these are the barriers and challenges which can very easily be taken care of. So this perception has to disappear. So challenges may be on the level of pediatrician, adult care teams, physicians team, parents, and the system and the administration. So, like pediatricians have been looking after these patients for years, and they might, have some attachment to these patients, and they might feel the missing or losing contact with these patients, which they cares for years. Uh, they might also feel that there is till now we have been looking after, and when the time came that we will be writing about these, so the patients are getting transferred. So the number will get reduced. Communication gap with the adult services, they do not have confidence at times in the knowledge, skills, and flexibility of accepting physicians, and the staff giving adolescents subtle non-verbal cues implying distrust about adult staff. That also is a problem, and certainly, if we are in private setup, then this has a negative financial consequences as well. And what happens when suddenly you announce that you are getting transferred? So this might be the reaction of this patient going to the crowded OPD, and he might feel that I also might be having some problems like these elderly patients have. He feels how my new doctor is going to be. The families also accept the transition to adult care with anxiety because they are used to the comforts of the pediatric care, their emotional attachment to the pediatric healthcare providers, grief and loss, uh, grief of loss of experienced when these trusted relationships end. So these are the problems that the families and the parents may face, and they have impression about the adult care that is fragmented, unlike the pediatric care which is under one roof. If you have a transaminitis, you need a consult, you are there, you send the patient to that person who is looking after the hepatology or gastroenterology, but it is not like the adult care teams where there might be a separate department for the hepatology or gastroenterology. So decreased level of resources and support available in the adult care teams, and difficulty finding primary care provider to coordinate. So if there are comorbidities, the person who is the primary care provider, that becomes very important. Uh, I think we have discussed this, and the physicians also might have a lot of questions. Actually, this happened when I started talking to my hospital physicians that there are now patients, and I want them to get managed in the medicine ward. So the quick answer was that we have never managed thalassemics. So these are always going to be the questions when the things begin. They have their own interests, and they might have very little interest in pediatric onset diseases. Clinics are full of elderly sick patients and often alienating for young patients. The extensive investigation and management reassessments soon after the first meeting may be advised by them. So that becomes a problem. And they, at times, they feel inadequately trained in care of the childhood onset diseases. Like if you talk of transition of patients with, say, diabetes or epilepsy or HIV, that might be better accepted compared to transition of cases like thalassemia or sickle cell disease, which were which are basically the pediatric onset diseases, and now only over the last couple of decades the survival has improved. So the inappropriate timing also could be a problem. Transfer out of desperation by pediatric team due to non-adherence and oppositional behavior of the adolescent. Now you don't understand this is important, go to the adult care team. So that is not really a good thing about the transition of these cases. But then, as I said, these are perceived barriers. So when there are challenges, certainly there are also opportunities. So we have to look at those. So this is actually we are almost 3.5 decades behind the developed world as far as the transition of care in not only thalassemia in different conditions is concerned. So this is the US, but then we can take advantage of what they are doing and they are learning from their mistakes. We can take advantage of all that. So this is gotransition.org in USA, which has 6 elements. And to this, the New South Wales of Australia has added couple of more. I would detail them in the next slide. And the Canada guidelines also says that the system of transition should be evaluated periodically. So we can take these 10 elements. That is, we should have a transition policy and guide, develop, discuss, and share of these policy. Communication with the receiving team of physicians, identifying local transition coordinator. It's important to teach these patients the self-care, and we should also assess the readiness about the self-care and the transition readiness, tracking and monitoring of these patients, and by the flow sheet registry, planning by developing a healthcare transition plan and by organizing the joint clinics of the physicians as well as pediatricians. Like in Lady Harding, we started a joint clinic because numbers were small. So we were doing it once a year. In the month of September or October, when the examination pressure is not too much, at that time we would organize one, and the patients will meet both the teams, and the physicians will meet the pediatricians, and then the transition would take place. And then finally, looking at transition completion, making a registry. And as I said, evaluation of the system is very important. So, secure leadership support and develop TOC policy at national and hospital level. Define the age of transition. Self-management and self-care patient empowerment is important. Transition initiation. The Western world, they write if the transition has to occur at say 18 years, we should begin talking about it 4 years in advance. But while we took up this matter with the DGHS, we decided that at least 1 year before actual transfer, the process should start. So communication with the receiving team of physicians is important, and organizing the joint clinics. And then finally, transition completion, transition registry and follow-up. In the self-management, this is the Oram's principle. Miss Dorothy Oram was a nursing officer who talked about the patient empowerment, self-management, and self-care. And she defined that as helping people to discover their innate ability to control their diseases and situations. So it's not only controlling their disease by understanding the treatment, and it's also about the situations like they should be able to put forward their needs to the administration when they are moving from one to the other setup. So this includes the understanding of the disease, treatment rationale, source of symptoms, recognizing deterioration, clinical versus lab-based, and taking appropriate action, how to seek help from health professionals, and how to operate within the medical system. And psychological empowerment of the patient is important for their active participation in self-care. So the methods suggested are by lectures or presentations, or photo presentation, educational pamphlet, peer training, digital forms by WhatsApp group, etc. And the content should have disease-related information, daily activities, fitness and health, nourishment, stress relief, job and home environment, time management, advocacy and expression and creativity of these patients. Parents, how the parents can help in this? They should understand that transition can lead to feelings of nervousness, excitement, hope, and frustration for all family members involved, and to have patience and provide support to each other during this process. Work with pediatric team to develop list of goals for transition and check in on those goals at each routine visit. So engaging and supporting the adult care team, the pediatric care team should own this responsibility. It's not, you are not washing off your hands from the care of these growing patients. You should facilitate communication with the adult care team, providing educational material regarding management, establishing constant point of contact for ready solutions to intercurrent issues. It's very important that the pediatric care person should be available if any medical issues crop up in these patients who have been transitioned to the medicine department. So physicians taking charge should educate themselves on the diagnosis and management, monitoring young adults and iron overload related complications, liaison with various specialists and psychological needs of the patients. One very important thing regarding the transition is the age, and uh, different countries have their own different ages for transition. The UK says around 13 years because they have pediatric age cutoff of 12 years. 18 years, the WHO age cutoff for pediatric age group. The adolescents are now part of pediatric care, so that is one thing. And actually, when we discussed at the level of DGHS, we discussed in large detail about this, the age of the healthcare transition. So if you look at the US, they are 12 to 14 years old. We should start the transition and complete by 18 to 23 years. So there is a flexibility in the age, even up to 23 years. If the patient is not mature enough to take care of himself, he is not transitioned. But cutoff of 12, 13, and 18 years have been suggested. Um, Across our country, cutoff for transition from pediatric to adult care are variable. Increasing the age of transition from pediatric to adult care from 12 to 18 years may have implications such as we need to increase the number of, there would be increase in the number of patients visiting the pediatric outpatient services as well as pediatric inpatient services. So increased patient load may require additional staffing. Uh, Given the economic implications, it may mean reducing the staff on the medicine side, but then the NMC regulations might come into play. So when this policy was uh, finalized, it was stated that the finally we should aim to 18 years of age as the transition age, but for the time being, in view of the implications, the cutoff age for transition of these may be allowed to remain the same as that for adolescents without special healthcare needs in a particular setup. However, in the long run, a uniform age cutoff of 18 should be made mandatory in the country. So this is at the national level. Hospital policy should have the list, the adult care team, counselor, nurse, transition coordinator, list age of transition, list when the process of transition will begin, how readiness of transition will be assessed, actual transfer and registry. Uh, I think we have stated that. So TOC, when they are ready, have a policy is there, designated faculty is there, the joint clinics are held, then there is a navigator for transition, which could be a medical social worker or counselor or nursing officer, and then registry and follow up. This is just at Lady Harding, we started after 4 years of negotiations, we started in 2008. So you can see the increasing numbers, and till 2022, we had transferred almost 150 patients to the medicine department, and they are really doing a wonderful job as far as care of adult thalassemics is concerned. So, as Dr. Arora pointed out, that not only for the thalassemics, now we are talking of the transition of care for all the youth with special healthcare needs. So, in 2023, early the president of Indian Academy of Pediatrics approached the Directorate General of Health Services uh, for this, that policy should be made, and a meeting of experts from pediatric and adult care teams of central government hospitals and AIMS was organized. And after deliberations on this subject, IAP was asked to prepare a policy document, which was submitted to DGHS. This document was circulated online among experts and finalized based on the feedback received. IAP was then asked to develop standard operative procedures for its implementation, which were finalized following deliberations. And after necessary approvals, the TOC policy and SOPs were circulated by the DGHS nationwide in December 2023. So in 8-9 months, this all got completed. The policy has been sent from the DGHS to additional chief secretary, principal secretary, and in different states, and also to the disseminated to along the SOPs to health care facilities ranging from district hospital to tertiary care hospitals. This has also been sent to the DG ESIC because that's a separate organization altogether, and to NMC. It has been requested to include the transition of care in the PG, pediatrics and medicine, and super specialty curriculum. This is the letter, covering letter of that policy document, which was sent. After that, a white paper was published in Indian Academy of Pediatrics Journal, Indian Pediatrics, April 2024. And so the way forward now is that two things are required involving the adult care teams, because finally they have to take charge and approach the state health ministries for implementation of the TOC guidelines at the state level. So I think that's the end. To summarize, improved survival necessitates transition of adolescents and young adults with TGT or anti-GT for better adult outcomes. Pediatricians' role is in empowering patients in self-management and empowering adult care teams. Physicians' role in educating themselves so that they could provide good quality care. And hospital administration should uh, form a hospital transition policy, and transition registry needs to be maintained. I acknowledge the data provided regarding their patients from these hospitals. Thank you very much.
Thank you, sir, for an elaborative discussion on this transition of care. I think Lady Harding was the first institute with your efforts to start an adult thalassemia care center. And now you have taken as a movement to make it a policy for across disease, not just thalassemia, to have transition of care at all hospitals all over India. And I'd like to say a few things regarding change of this age, transition of age. I think to my mind, it should be, you have said 12 to 18 years. I think the best would be 18, because reason being, even otherwise, our children, our thalassemia patients are not matured enough at 12, 13, 14 years or so. And they are not only short stature or they have some problems. Because first of all, they require the tender care and love of a pediatricians. And the adolescent, as you told, the problems have been taken care by the pediatricians. And moreover, it's schooling as well, because we have our 10th and 12th class standards board examinations, which are, if we take transition of care from say 14, 15 years or so, then they may have more problem in education as well. So to my mind, 18 is the best, and I can say we should start by 16. Instead of 1 year, we should give 2 years for transition and have, you can say, joint this meeting with the adult and pediatric physicians every 6 months. So it should be easy. And it has to be, you can say, through a coordinator. That is must. Because if the patient is directly transferred from pediatric to adult, they may face many problems, because where they have to go, to whom to meet. As you said, the primary care physician is most important. So those things are there. So I like, if at all, Dr. Michael, because he's there. I think we must have his expert views, or Dr. Andula, whosoever is, both of them are there. Dr. Michael, please. We can't hear you. Dr. Michael, we can't hear you. I think
Since they are taking
yes.
some time,
Okay.
let
Anybody
let
else?
me
Yes.
let me answer some of your comments that you have made. See, there is no doubt that the age of transition should be 18 years. Now, the question is, at the present time, as I mentioned, the implications, they are there. So, keeping the patients, some patients, say beyond 12 years, some patients up to 12 years might be counterproductive. Those who are, you say that developmentally they are, not normal, they are short stature, they might feel even more psychologically disturbed that this fellow of the same age, he has got transition to the adult side, but I am not getting that. So that also one has to take care. The second thing about the examination part, you said, this is actually at the 18 years, this becomes more crucial because the 18 years is the time when a normal youth, the adolescent would be appearing in his 12th examination. But these children also may be 10th or 11th, and this has to be very carefully decided that if the child wants to stay till the board exams in the pediatric care, he should be allowed to stay. So that is what we had thought of at that time. And these actually finer things can be taken care of at the hospital level. But more important is that hospital should, in fact, I had requested the DGHS, Dr. Sunita Sharma, that in the central government hospitals, at least during her time, the hospital policies should be, they could be prepared and they could be put in place, not only for thalassemia, several other diseases. Like I know Kalavati Saran has a very growing population of the diabetic patients, and the diabetes of pediatric age group is entirely different from adult diabetes. So someone has to take care. It's not that they are transferred and anybody can look after these patients.
Yes. Dr. Michael, are you ready? No, we can't hear you. Sorry.
You can check with Dr. Androla.
Dr. Dula, if she is there, that different device. No.
Okay.
Sorry. So we can't hear Dr. Michael or
Anyway,
Andrula.
yeah, we can take
Anybody
comments
else?
from others.
Any comments from Dr. Neeta, if you're there?
Yes, sir. Yeah. So I think there's some connection issue from this side.
Sorry, can you hear me now?
Yes.
Yes.
Yes, Dr. Michael.
Όχι, τώρα δεν υπάρχει περίπτωση να με ακούω. Δεν τους ακούω. Sorry, you can hear me?
Yes, Dr.
Yes.
Michael.
Can hear you.
Okay, this is very strange. Sorry, everything that has been said by yourself and Dr. Chandra is obviously absolutely correct. I just wanted to consider some issues that may be a problem that we have to remember in this transition process. The adolescent is also a student, and the young adult is also somebody who is going to employment. And in order for them to facilitate, if you like, the transition in life, they would need to have flexible hours. They would need to be able to have transfusion, for example, either in the evening or at weekends, so that it doesn't interfere too much with the demands of education and the demands of employment. I just wanted to add this to the problems that we're talking about.
Yes.
Absolutely. Absolutely. These issues have to be taken care of while the transition is being planned.
We must have either round the clock or you can say, and on Saturday, Sunday, and evenings, we should have transfusion facility available so that even adult thalassemics of the the growing thalassemics can take a regular transfusion without, we can say, hampering or disturbing their education or employment. Yes, Dr. Nita.
Thank you, sir, for the wonderful session. So I totally agree with you regarding the age of transition. And I feel as part of transition, when we start preparing for transition from a couple of years prior to the actual transition happening, we could also incorporate some kind of psychosocial sessions and career counseling for our thalassemia patients. So because there are, if we can career them, so that can help them plan their work accordingly, and how they are getting support from the disability section for higher studies. All this can be counseled from the beginning so that they can plan their transition to adulthood and to a successful professional life very well. That's all from my side, sir.
Okay. Anybody else from the audience? Tom? So if there's
Dr. Vinita is there or she has
no,
left?
she is actually she had another meeting, so
Okay.
she has left, and
Yeah.
Dr. Sunita has not joined.
Okay,
Maybe
so I think before we close, that let me make one or two comments, rather request to you and to Dr. Nita Radhakrishnan. See, I think Dr. Nita, you did a wonderful job in mapping out the thalassemia facilities in the country, thalassemia care facilities in the country. I think for the assessment of the thalassemia, their age group, their education, their employment, though that number I had presented was just 500, I think over the country, a large number of patients would be doing really good. Their marriages, fertility, and everything. This needs to be, mapped, as you say, or maybe a observational study can be planned on that. So that is one thing. And second, regarding the self-care, as Dr. Neeta also said, that some kind of guidance to them regarding their own psychosocial adjustments, etc. So the self-care of these patients, there is some of them learn by, they are intelligent, they might learn. Some families are intelligent, but a concerted effort should be made in the like in, if you recall, Dr. Arora, some 15, 20 years back in our conferences, we used to talk transfusion and chelation. Then we added a talk on monitoring of these patients. So similarly, now transition of care came up nearly 4 or 5 years back. Now we should also add the self-management of these patients, how to, self-empowerment of these patients. So the ORM principles. So based on that, and I think that will be the key to a successful transition. So these are two requests from my side to both of you. I think because I would be out of my institution, but I'm certainly available for any kind of, deliberation or any activity related to these things. Thank you.
Sir, one thing more, even WHO has the World Patient Safety Day, and in one of their this World Patient Day, they have the self-care management was a theme. So we'll be holding more, you can say, seminars on that. And we have been very proactive. I think you must have seen even the prescriptions we have made with National Thalassemia Welfare Society. It contains so much material. The patient is, you can say, so confident or so informative that he can self-manage. He knows how when to test for, if he's taking Calpha, Hydria, he should take for this CBC, and when what should be the values when he should test for ferritin, how much blood to maintain, what type of blood. So even in my every prescription, we have so much information for the patient that patient can care himself or herself very good. And so everything is even investigations. Which investigation to be done when? Which is to be done every month, once in a year, after 10 years, or as and when required. Vaccination, what vaccination before spectrum. So we have been already into this, but certainly you said we should have more, I can say, sessions on this so that patients be encouraged on self-management. Sir, you're mute.
Maybe we can develop a module on
Yes.
self-management of the
Yeah,
self-empowerment of.
one thing, I just want to know one thing,
Ji.
Dr. Jagdish and Dr. Arap.
Ji, sir.
Are there any study we have done? We have done about the perception of these patients and how satisfied they are once they have been transitioned to medicine, say in the Lady Harding. What
Lady
has been
Harding.
their perception? Any
No,
experience from the
no,
patient side?
I don't think there has been any study, at least till the time I had left, and after that also I think there no study has been done. But there are like the Western countries, they are evaluating their system. So one, this thing can be done. Those who have been transferred to the adult side from Kalavati, they can be approached, and they might even tell that over the last, because this transition has occurred there in 15 years back. So the perception of those patients who were transitioned at the time when the system was just taking shape, just beginning, may be different compared to what it is now. That is one. Second is that we can have the assessment of the patients who are now 16 to 18 years of age at
Yeah,
this point of time, and then putting them through a module on self empowerment. And after that, we see how better they are equipped in handling their own conditions. So
yeah.
these
Any
studies
kind
are
of
required.
improvement
These
required?
studies are required, but right now there are none.
Sir, we can
Yeah, any
plan
kind of
studies.
improvement? Any kind of
Hmm?
improvement we can do? Any kind of change they may suggest from their
Yes, yes,
perspective? So that
yes,
is
yes,
also
yes,
important.
yes, yes.
Good, very good session. I enjoyed fully. Thank you, everybody.
We'll take up on that employment survey also, sir, because now there
Yes,
are
yes, yes,
documents which are coming
yes.
up on employment in severe different chronic diseases. And as far as I know, all thalassemia hemophilia patients who finally are employed, they also file IT returns like any one of us. So it is so what we are investing is in a future into a productive a human being who is actually
Yes, yes,
contributing
yes.
back to the economy. So that
That's
data
it.
is very
That's it.
important for
Yes.
advocacy also, to know how many percentage of thalassemia patients are now entering gainful employment. Thank you,
And
sir.
as Dr. Dubey said, we can have a study this, and that's not difficult. We can have some like monkey survey form or like that. We can send to these patients because they are all educated. So we can ask them what they were feeling when they were the pediatric care, and now they are the adult care. And that too, we can have difference of three different stages, say 5 years back and now. So that can also be taken care. Yes, we'll certainly plan that. Okay.
Can we
Ji, sir?
now can we close the session?
Yes. Anything, we think everything, discuss everything. Manisha, if at all you want to say anything, okay?
Thank you so much, sir. I think, sir, we have one or two questions in our chat box, if you would like to take.
Yeah, sure.
Let me see. Uh, One is blood transfusion is an important part of management of thalassemia care, but still many blood centers are not providing leukoridase, RH phenotype blood, and that screen blood. How government can help in making it mandatory? I said this is not related to today's session, but if at all, sir, you want to say anything?
Not really unrelated question, but the persuasion is something which is required, and maybe I don't know to which place Dr. Bharat Singh is writing about this. So I think the patient bodies and the organizations like
Ji.
Thalassemics and National Thalassemia Group, they should make it more efforts into this. The states where these facilities are not there, they should be provided. And I think the National Health Mission is already having
I think
the,
Mrs. Vinita
the
would have
system in
been
place.
better person to
Yeah,
answer
yeah.
this question. Vinita Srivastava, she has just left. And another is the cost of death. So I think it's okay, fine. So we can close, and thank you everybody, and especially Sir Dr. Jagdish Chandra, this and for
Thank you.
Dr.
Thank you
Michael
very
and Rula
much.
for joining from abroad. Dr. Dubey, Dr. Bharat Singh, Dr. Neeta, and all the audience who joined it, because it's always because of audience we are encouraged to have such type of more sessions. And thank you, Manisha, from Eco India, for giving us an opportunity to have a webinar on such an important topic, which should be taught by, I can say, considered at all the institutes, whether the medical institutes or government hospitals, private hospitals, to have a separate thalassemia center for adults. Thank you.
Thank you, everybody. Thanks.
Okay,
Bye-bye.
thank you. Thank you.
Thank
Bye.
you so much, sir. Thank you so much for organizing this session.
Okay.
Thank you. So with this, I'll close the session.
Yes, okay.
Request all the participants to just share your feedback. I have put it the link in the chat box. You can share your feedback. Thank you so much, Dr. Jaya Sarla, for organizing this session. This was a wonderful session. It was a last minute thing, but it turned out really well. So thank you so much, sir.
Thank you.
Bye bye, sir. Take care.
Bye.